So we'll go ahead and welcome everyone. It is great to have you all join us. I know that there's been some weather complications throughout the state. I'm really grateful for everyone who's been able to still make time and brain space for such a really, really important topic. And I know I'm just thrilled to get to be joining these incredible women for this panel discussion today. I am Zoe Clark. I'm the political director at Michigan Radio. We're the state's largest NPR affiliate based in Ann Arbor, which we are. The station has power today, which is where I am based. Second, I want to let you know I've been talking a lot, but we want to hear from all of you who are in the audience today. So if you've got questions for this incredible group of women, go ahead and put it in the Q&A function at the very end of the Zoom. We're 3.5 years into this whole Zoom thing. We know how to do that. So if you go in the Q&A and put your questions, and hopefully there will be time to get to some of them as we wrap up. And then just one final note, I want to let everybody know that today this webinar is being recorded. So with that, I just so want to welcome and thank today's host, Tereska Desjardins. She is the plan president of Molina Healthcare of Michigan. And Tereska, I'm going to go and turn it over to you.
Thank you, Zoe, and good afternoon to all. On behalf of Molina Healthcare of Michigan and the Molina Cares Accord, I'd like to welcome all of our guests, nearly 200, joining us for this very important conversation, Healing Lives, Tackling Hurdles in Children's Health Care. The Molina Cares Accord was established by Molina Healthcare as a commitment to building stronger communities one life at a time. This virtual panel is just one of our many efforts through the Accord that aims to improve the health and well-being of our communities. The experts joining us today will discuss how health and healthcare inequities impact maternal, infant, and children's health outcomes and ways to meaningfully address existing disparities to achieve more just and equitable care and outcomes for pregnant women, infants, and children. At Molina, we understand the importance of and the need for collaboration with our partners across different sectors of the healthcare ecosystem to best accomplish this goal. Therefore, I'm honored and thrilled to have with us a great group of very distinguished experts who are leading the charge on creating a multifaceted approach, many of whom I am proud to partner and work alongside to address this very issue. To kick off our conversation, I'd like to introduce today's keynote speaker, Dr. Renee Branch Kennedy, Chief Executive Officer at MPHI. Dr. Kennedy leads the strategic direction of MPHI as they strive to build a world-class infrastructure to support the Institute's diverse and progressive program areas and projects while establishing and maintaining stakeholder relationships. Prior to joining MPHI in 2014, Dr. Kennedy served as Health Officer and Director of Ingham County Health Department. She is recognized as a national thought leader in the areas of health inequities and disparities, cultural competence, and social justice. Dr. Kennedy is an outstanding public health advocate, researcher, educator, and facilitator. She earned her PhD in medical sociology from Michigan State University. Go Green. She has a master's degree in public administration from Western Michigan University and a bachelor's degree in public health nutrition from University of North Carolina at Chapel Hill. Thank you, Renee, for being with us today. You've been such a great friend and partner over the years, and I truly appreciate your exceptional leadership in Michigan and beyond. I know this topic is a very personal one for you.
Thank you, Tereska. And I'm just excited anytime we have an opportunity to dialogue about this critically important topic. I am all in. So I'm going to pull up some slides. And what I'd like to do is really just give you some context for your hearing, for your thinking, for your listening. I love that part of the title, Healing Lives, because that is exactly what we are all here for. So let me just dive in. I want to give you a reflective question to just have in the back of your mind as you're hearing our panelists speak. So what would our work look like if we applied health equity strategies to transform the systems that create health inequities? Let's just mull that over. Let that be the agitational prompt, as we call it in facilitation, to guide our thinking and our learning today. You know, this is not a new problem. If I look at quotes that were written back in somewhere between the 15th and 13th centuries before the Common Era, here are a couple of quotes. One says, "And this woman's child died in the night because she overlaid it." Safe sleep, co-sleeping, child health, right? Another quote, "And she was having great difficulty in childbirth. The midwife said, 'Don't despair.' As she breathed her last breath, for she was dying, she named her son." Maternal mortality. The Spanish philosopher, whose quote we know well, "Those who don't know their history are destined to repeat it." And the history is complex. This is a picture of three critically important lives. Anarcha, who is kneeling on the table, Betsy and Lucy, who are peeping behind the curtain, three enslaved women who were experimented on for gynecological surgeries that were performed by Dr. Marion Sims, the one standing in the front, without any anesthesia, learning how to repair fistulas on a woman who lived and breathed. These are the histories that we can't forget. Really, our infant mortality story, this child health story, has been a deja vu story. I mean, in the early 1800s, Black babies were twice as likely to die as white infants. In the late 1900s, Black babies remained twice as likely to die as white infants. And today, the story just continues on and on and on. 700 to 900 women die every year in this country due to complications related to pregnancy and childbirth. Another 50,000 that we don't really talk about suffer severe complications. We sometimes refer to those as near misses. I personally was a near miss in 1989. The rates of maternal death among Black women, 3 to 4 times that of white women, and 60%, over half of those deaths were preventable. That meant moms could continue to love their children, moms who could continue to support other children that they had, spouses, and so many others. And this difference has been unchanged in the past 6 decades. Also, the latest data I had looked at, 2017, the US had the highest maternal mortality rate of any industrialized nation. And that rate continues. I don't know, are you guys hearing an echo, or is it just me now? It just started. Tereska, are you hearing an echo? No.
Yes, I'm hearing an echo. I think that they're working to mute.
Okay. All right, we'll keep moving.
Sorry, I think we're okay now.
Okay, thank you. Dr. Mahmoud Fatala said, "Women are not dying because of untreatable diseases. They are dying because societies have yet to make the decision that their lives are worth saving. We have not yet valued women's lives and health highly enough." And you might read the sort of weight of those words and want to say, that's not true. We value women. We really do. Well, I would argue that it's a condition of intent versus impact. We might not intend to be marginalizing women's lives, but indeed we are. And I just honor some recent maternal deaths. Kira Dixon Johnson, whose husband came and spoke at the Michigan Maternal Health Summit a couple of years ago. Shalon Irving, a powerful researcher at the CDC who studied maternal death and became one of the statistics that she studied. Shamani Gibson, Amber Isaac, beautiful women, mothers in the New York area, and most recently, Tori Bowie, who is an Olympic medal-winning athlete. We tell this story over and over and over again. In the late 1990s, we released a series called The Unnatural Causes Video, Is Inequality Making Us Sick? And there was a part of that video series entitled When the Bow Breaks. Toxic is a newer video movie that was produced, a Black woman's story. Most recently, on Hulu, you can see a story, Aftershock, that tells Shimani and Amber's story. We keep telling these things over and over and over again. It's also one of those everything old is new again, because it is the context of these women's lives across their life journey that ends up resulting in these outcomes. So this is a clip from a small town, Gila Bend, Arizona, the Gila Bend Herald in 1970. And it says, no news value at all. Two little girls just playing peas porridge hot on the school grounds don't have much news value. They're not like racial riots and the interracial council meetings and big quarrels about school integration. However newsworthy or not, they're a lot nicer to look at than the pictures of the big cities' tear gas throwers. These young girls began to experience a context that would follow them into their adulthood. And so recently we've coined this phrase, productive outrage, because quite candidly, we're getting pretty sick and tired of having the same conversation over and over again. And productive outrage is not righteous indignation. Righteous indignation inspires us, but it doesn't equip us. And productive outrage is not political will or social will. You hear us say, we don't have enough political will or social will. Well, it's out there, but political will and social will start us, but it won't sustain us. So how do we move from admiring this problem? And so we have defined productive outrage as a sense of indignation that drives sustained change. We want you to leave this webinar productively outraged and ready to execute change. I like to also consider it the Popeye principle. Some of you may remember the Popeye cartoon, and Popeye said, "That's all I can stand, and I can't stand no more." We are tired of reading the same statistics, telling the same stories. And so we're endeavoring through productive outrage to be disruptive, not necessarily destructive, which can damage relationships, but disruptive and transformative, not just accommodating that these are the statistics that we see. Because of productive outrage, we say what we mean, and health inequity, we have a real clear lens on what we mean when we say that. We're talking about these population differences that are systemic. They're patterned, meaning they're repeated. No matter where you are calling in from today, you can look at the parts of town where moms are going to live a much more at-risk life than others. But it's also important because this definition invites values to the table. It says it's also unfair and unjust. And most importantly, it's actionable. Sometimes we feel like we can't fix racism or we can't fix poverty. All of those are socially constructed. We created them and we can uncreate them. So my friend and colleague Paula Braveman says, well, this is going to require us to deal with these obstacles to healing lives, as our title says. We got to deal with poverty, discrimination, powerlessness. People may be employed, but aren't making a living wage. They have to work 3 jobs to try to barely make ends meet. I would argue that health inequities are the moral drive that push us to address health disparities and all of the racialized context. So all of the things that happened in these young girls' lives, including this young Black girl not being invited to her best friend's slumber party because of the color of her skin, carries with it. That is how racism and oppression get under the skin, we call it. I know that story because that young girl is me. And that young girl also grew up to be a young mother who gave birth to her first son, that is my son, Mark Howard, who was delivered at 29 weeks, way, way too small and way, way too young. And although he lost his life battling the consequences of his prematurity, dying when he was 6 months old, that journey still positioned me to be the mother of 3 additional sons, having the frame, having the productive outrage, to commit my life to drive change, to entrust the job that I've been given and using it to advance change and improving the lives of others, healing lives. So again, what do we need to do? What would our work look like? And let's assume that we know our work needs to change in order to create systems that reverse health inequities. And so I would argue that there's room at the table, the title of a book I'm preparing to release, but there's room at that table for us to solve problems, to co-create, to be solution driven. And I love this quote by Shirley Chisholm: if you come up to a table and they don't give you a seat, bring a folding chair. There are some spaces where we don't want to have this dialogue, but have the dialogue we must. And so I challenge you with a call to arms from the Adinkra symbol for vigilance. And thank you for taking the time to be a part of this webinar and this dialogue. Thank you, Tresca, and thank you, Zoe.
Dr. Kennedy, thank you. I hadn't seen that presentation beforehand, and so I want to just sit in it for a second. And I'm hoping that those folks who are on the panel and that those folks who are in the audience can just sit with it for a second as well. You shared a really, really personal story, and I'm grateful, and I want to make space and honor that for a moment.
Thank you. Thank you.
Dr. Renee Kennedy, you are something else. I want to also thank Molina Healthcare of Michigan, along with Molina Cares Accord, for convening this panel, as we said, of really true experts. And as you can tell, a really important conversation that we're going to have. So let's welcome this industrious panel, shall we? We have Megan Groen. She's Medicaid Director at the Michigan Department of Health and Human Services. Hi, Megan.
Hi,
we also have Amy Zagman, Executive Director of the Michigan Council for Maternal and Child Health. Hi, Amy. Bernice Anthony, she's lead consultant at Southeast Michigan Perinatal Quality Improvement Coalition. Hi. And finally, of course, staying with us is Dr. Kennedy. Amy, I want to start with you and just sort of do some level setting, right? Can you just sort of give us the big picture view of the hurdles that you see pregnant women and their children facing, from the work that you do at your organization, particularly those from underserved populations?
Yeah, thank you, Zoe, and thank you to everyone who's here today for this important conversation. Dr. Kennedy is always a hard act to follow, so and I'm really grateful to be here in this group. I wanted to talk about hurdles. The biggest hurdle we hear from our members and community partners for people in the perinatal period, if you think about that being pregnancy and the year that follows, is being connected to all the resources that we know that they need and want to care for themselves and for their baby. In the US, we often talk about family values. We talk about how important families are, but we don't make it easy for people to find the supports and services that they need. We have healthcare and social support services systems that are not very intuitive to navigate. Honestly, we set systems up so they really make sense to the people who set up the systems. They don't make sense to the people who need them. They're built really, in many cases, on racism and classism. That's the way the systems were built, and they're still riddled with those things. And so the families that are furthest from opportunity get left out. They don't have the trust, the time, the bandwidth to access the programs that we think that we've so thoughtfully built specifically to help them. So, there's often a disconnect between what's available and individuals who can find them. I really think, I'm hoping that we're going to talk today in our times about some big societal shifts that we need to make about things like paid family leave, and then, really thoughtful local decisions about things like co-locating a pediatric office and a WIC clinic. Make it easier for people to find those things. In short, I just think it's the longest set of hurdles that you can imagine. I mean, all of us who've been through having a newborn, having a family, knows how hard it is. And I'm with Dr. Kennedy with some productive outrage. I'm hoping everyone who's on this webinar today is thinking about what hurdles are part of my work, part of my life, that I could get on the track and get out of the way for a family who's just trying to do the best they can.
I wrote in really big. I wrote in really, really big letters. Oh, I think the host has muted me. Letters that says productive outrage. I want to, like, I don't know, put that just somewhere in my office and just continually look at. It looks like we have Vernice back. Vernice, I'd love to turn to you about what steps we can and should be taking, that providers should be taking to address these challenges.
Well, thank you. Thank you, Zoe. Can everybody hear me?
We can.
Here going on. Thank you, Renee, for a fantastic, overview, as well as your comments. What can we do? Just quoting Renee again, destiny not learned is destined, history not learned is destined to be repeated. First thing people need to do is learn that history and accept the history, of the impact of slavery and racism on the way that the healthcare delivery system is structured to function today. You've got to learn your history, implicit bias training, anti-racism training. I have some links in the chat for our SimQuick website, as well as our Detroit Health Equity Resource website. Please, I'm asking people to use that. There are tools available. Learn your history, accept it, self-introspection, and accountability for outcomes. We have to accept that as healthcare providers. We've got to accept some level of accountability. I will mention my AIM, Michigan Alliance for Innovative on Maternal Health. Hospitals throughout Michigan should be participating in that program. CDC and MHA sponsored, where evidence-based data has shown that when providers implement and execute a certain set of standards and policies around the preventable causes of maternal death, we do reduce maternal deaths. So hospitals on the call, check out, make sure your hospital is participating in my AIM and reporting that data, and then implementing the changes to improve. Those are some things that we know that works. Another thing I have to mention is doulas, midwives of color. Great, thank you to the state, Megan and others, for the advances we've made on expanding doulas in the state of Michigan, getting them paid by Medicaid. We know that both midwives and doulas from the community, and also an expansion of African-American physicians and other providers, makes a difference. So whatever role you might be on this call, if you are able to influence that, now is the time to do that. Recognize that, take advantage of the system that we now have in place in the state of Michigan, as relates to expanding and utilizing doulas. I want to mention centering pregnancy. I hope that's a term many of you have heard. We know it works. The governor has supported it in her proposals for the legislature. We're waiting for that to be signed, not signed yet, but centering pregnancy, group interaction, especially pregnant and postpartum African-American women, mutual support has been proven to make a difference. We will be able to expand centering pregnancy with the new budget that's coming into place. Those programs need to be expanded. There are things that work, as Renee said. All this is not rocket science. We know what to do. Active listening to Black women. active listening, listening to hear, listening to learn, eye contact, not looking at the computer when you're visiting a patient, eye contact. It has been documented again and again and again that Black women are not listened to by healthcare providers. And if you have some implicit bias training, you'll begin to pick up some tools to help you improve that. We within StemQuick have been videotaping the voices of 100 Black women about their prenatal or postnatal journey. That will be available soon, but that's another thing that can be done. And finally, collaborate, collaborate, collaborate. Get out of your silo. Collaborate with community-based organizations. Community-based organizations collaborate with healthcare systems and health plans, which is what the regional collaboratives all do around the state of Michigan. I happen to represent Region 10, which is Wayne, Oakland, and Macomb counties. And we do have at the table the birthing hospitals, the health plans. Thank you to Melina for sponsoring this particular event. Also community-based organizations, doulas and midwives. When we focus on some common goals, specifically on maternal and infant mortality, we really can move the needle. And just rephrasing again, Dr. Kennedy, it's the will to do. Many of the tools are in place. It's the will to do. So those are just some of the things. I have a very long list, but I just wanted to hit the high points in this response.
We are grateful for that list and for your work. Thank you. I think what's really thrilling too is seeing the number of folks that are on this webinar. Oftentimes it feels like we do have these conversations that can be siloed. And then you're like, where are the stakeholders? Who are the stakeholders that need to be at the table to hear this? Or to Dr. Kennedy, Shirley Chisholm, to bring the folding chairs to the table to have these conversations. And I think, seeing the participants on this call, these are some of these stakeholders, who are part of this conversation now. Well, and Vernice, you talked a little bit about the state level. You talked about the governor. There seems to be some new and ongoing efforts in maternal child health. Megan, can you share what some of those efforts are and how MDHHS is working with others in the healthcare ecosystem to sort of overcome this issue of inequality in care?
Absolutely. Thank you for the opportunity to kind of share some of those and some of the work that we've been doing over the last couple of years. And certainly to Dr. Kennedy's point, there's a lot that can be done really what it takes sometimes is really grateful for those who brought a folding chair. Part of my job is to make the table bigger, right? And to make sure that we've got the right people in the conversation. And part of that is because improving health outcomes and overcoming health disparities is complex. It requires multi-pronged solutions that improve access to care and resources, but also that address the inequalities that led to health disparities. And so one thing that the governor did when she first came into office was really talk about the Healthy Moms and Healthy Babies initiative. And this is a piece we've seen in the budget for the last couple of years. And then the governor launched it to do just that. So at the time, there was a huge focus on infant health, which is wonderful and something that we all support. But in our opinion, mom was a little lost in the conversation. And one of the best ways we can have a healthy baby is to have a healthy mom. And so we really looked at expanding postpartum Medicaid coverage for a full year, Medicaid reimbursement that we just talked about, and expanding our home visiting programs. I just want to take a moment on those doula services because we really understood that needed to reach into the community and that needed to be accessible for people. So one thing that we did is our chief medical executive, Dr. Bagdasarian, she issued a standing recommendation for doula services that they're medically necessary and that they should be offered to families covered by Medicaid insurance. So by making this standing recommendation, she addressed a federal Medicaid requirement that doula services must be recommended by a licensed healthcare provider. And so now in Michigan, doulas and their clients do not need a referral. We were the first state to really go and use this standing recommendation to expand access to community-based doula services. And I think that that is really important. All of these policies are proven to improve maternal and infant health outcomes and to save lives. And so we are continuing those investments in the budget that we anticipate will be signed real soon. And so, you know, a couple additional pieces that we're seeing to build upon the work that's already been done is removing the 5-year waiting period for children and pregnant women legally residing in Michigan to access Medicaid so that they can have that important coverage. Supporting the Medicaid state plan amendment to include Plan First. Supporting increased access to the centering pregnancy group of prenatal care in our birthing hospitals, and increasing investment in the Michigan Perinatal Quality Collaborative to support all of the great work Bernice and others are doing. So those are just a couple pieces, and you know, some work that we're really excited about.
Megan, thank you for that. Dr. Kennedy, I want to look to you, going back to the things that you're saying need to be done, the things we need to be talking about. How does that resonate with you in terms of, you know, solution-oriented thinking in this state?
It's not a matter of head knowledge. We know what to do.
Right.
It's a matter of conviction and willingness to do it. I love Bernice distinguished learning history and accepting history. We've got a little bit of denial happening in society. We want to just say, oh, if those moms would just take better care of themselves. And but the easy choice, the healthy choice, is not readily available to. So I think some of the policy decisions that Megan's describing is going to make the healthy choice more readily available to moms and families.
The actual doing it, right? Bernice, how can community organizations and others in the healthcare ecosystem actually help to address maternal and infant racial disparities in order to actually achieve real and better health outcomes?
Community-based organizations, advocacy.
Mm-hmm.
Advocacy is extremely important. Being willing to recognize that system change, which is what we really address a lot in terms of advocacy, requires active involvement of community-based organizations and community. Amy can't do it by herself. We have got to be heard. Community-based organizations must be heard. But they also have a major role in empowering and educating their community. You know, empowering their community, not just with the information, but also the avenues to advocate, helping them be heard, being a voice for them, you know, as well as obviously community education. Sometimes it's not what you say, it's who says it, which we learned a lot, you know, from the COVID, you know, vaccine efforts. Community-based organizations can be very powerful spokespersons to their community, you know, not just in terms of empowerment, but also in terms of sharing resources that are both acceptable and accessible, you know, that the community will be using. And I really want to add a greater inclusion of Black fathers. I think we've really missed a major piece of what is necessary in our Black communities, and they're actually there. Fathers are everywhere. However, we tend to not recognize, you know, Black fathers, and we're doing some work within SimQuick, certainly in bringing Black fathers to the table. But that's a key component of our communities and our families. So those are just some of the things that community-based organizations can do, and we do have many working with us within the SimQuick within our region.
Zoe, if I could just tag on to
Please.
those comments. You know, oftentimes when we see infant mortality statistics or maternal mortality statistics, we think about how many babies are dying, how many moms are dying, but those measures are actually a broad indicator of community well-being. So it's a community measure. It's not just what happened in that delivery room, because we know in societies and communities that are well-equipped, then it's not like a vulnerable mom, it's a mom made vulnerable by her circumstances. So when Vern talks about communities, recognizing that as a community indicator is really important.
Well, thank you. And it actually takes me into my next question, which actually talks a little bit about statistics. And I want to read this because it's just sort of shocking. So I'm going to read the number actually here. And Megan, I'm going to look to you. So in 2019, a study was published in NCBI, and it noted that an increase of 1 PCP per 10,000 population was associated with 7.08 fewer infant deaths. Like, I just want to repeat that because we're talking about lives here, right? Like, these aren't just, I hate when we're talking about statistics, but they're actual lives. So with 7.08 fewer infant deaths per 10,000 live births. So, I mean, Megan, understanding this correlation and the importance of primary care and infant mortality, what can we do as a state to improve access and connections to primary care physicians?
Yeah, thank you. I think that that's such an important piece and such an important question. And access to primary care physicians is a problem we're experiencing in Michigan and across the country, right? So we could have an entire panel on this issue and how strongly the impact is, especially in our rural communities, where they've got few OBGYNs and labor and delivery options are limited already, right? So successful solutions in this place are going to take universities, health systems, health plans, government, communities, and all of us together. So I think part of MDHHS's role is to really convene partners and advance policy solutions. So a couple examples of some of the actions that we've taken in the state in conjunction with others first, financial incentives, right? So MDHHS provides an increased payment rate for Medicaid primary care services. And that increased payment rate delivered by Medicaid providers is for family medicine, general internal medicine, pediatric medicine. And that's one piece that we can really look at. Another piece is, and I know it was a little while ago now, but expanding Medicaid coverage in general, right? So when Healthy Michigan, when we elected to expand Medicaid coverage, the state customized its program, wanted to emphasize primary care, preventative health services, and Medicaid expansion doubled access to primary care. So one piece that we're doing today is really trying to make sure that all of those people who have come onto Medicaid that are using those services, they've got to go through a redetermination process for the first time in 3 years. During the public health emergency, they were able to stay on coverage. And we're going back now that the federal PHE has ended, we're going back to our previous policy, which is a federally mandated policy that we do have redeterminations every year. So a lot of our effort right now is to making sure that people update their addresses, that they return their packets, that we're doing everything we can to encourage people to continue on and make sure their coverage is there. Another piece is expanding loan forgiveness and scholarships, encouraging people to become primary care physicians, right? That's a big piece. The Michigan State Loan Repayment Program offers $300,000 to repay student loans if physicians agree to work consecutive 2 years at nonprofits providing primary health care. I think that's a big piece. And one thing that I'm not sure is highlighted often enough in that program that I think is really important is that there's a specific objective of increasing the number of obstetric service providers in underserved areas. So the numbers don't sound huge, but 14 participants over 2020 to 2022 in Northern Michigan, obstetric service providers is a big number, right? Like, we're doing a lot to make sure that we get physicians and primary care and OB services to the people who need it most in Michigan. So those are just a couple, but please know it's something that keeps me up at night and that we're working on every day.
And when we're talking about those statistics again that I noted, that does, I mean, that is a correlation right there. Let's see, Amy, I just again, I'm getting back to this kind of level setting, but what can we do to give Michigan babies the best possible start in life?
Yeah, thanks, Zoe. I didn't write the question, but it's the mission of a collaborative group that we have called Think Babies Michigan, which includes the Council for Maternal and Child Health and also some other advocacy organizations and an army of parents that we've built who we want to engage, like Vern said, to be advocates, to really share what they need and what they want. So, building off of what we've identified through our work with them, it's really recognizing that every parent wants to be the best parent they can be. And so often it becomes an issue of like I talked about before, trust and resources and time. And so, it's everything from tax policy, and do we have policies in place that really help families be economically secure, to actually having services and in place in areas that are accessible to them. So we need to assist parents with finding all the things that they need: preventive health care and developmental supports, like access to programs like and then quality and affordable childcare. I mean, we're really here to talk about something else, but for families, those things are very intertwined, correct? I mean, they don't stop thinking about their child when the child goes to daycare, so they can go to work, so they can put food on the table, so they can, all these things in real life, as I said earlier, are not siloed. For families, they're very, intertwined, and we need to have policies that recognize that and sustain that. So I mentioned Think Babies Michigan. Folks can find it at thinkbabiesmi.org. It's a way, I think, for anyone to be involved with a broader coalition that's thinking about broad-based strategies to really improve the lives of infants and toddlers in the state. So I encourage people to look. We're trying to highlight the true cost of providing quality services like childcare and like early childhood home visiting, which is an amazing strategy where trained providers can go into the home of a pregnant individual or family with a young child and really help them access services. But more than that, parents report back, the best outcome of home visiting is that it increases their confidence and their parenting capacity, which, again, I'll just circle back around and say, you're going to be hard pressed to find a parent who does not want to be the best parent they can be and probably parent better than they were parented to. So, we've got to figure out how to listen, as Vern said, find out what are the barriers that are getting in the way, especially for Black and Indigenous families, and get those hurdles and those barriers out.
Well, Dr. Kennedy, I'm going to turn to you then, as we're talking about these sort of additional steps that are needed. Your point of view to mitigate maternal and infant health disparities, particularly among historically marginalized populations.
Yeah, we have to begin thinking about the system. We describe the mission of public health as assuring the conditions necessary for good health. And we're just trying to invite everyone to, we're so socialized to just look at the person, interpersonal. What's that individual doing? How am I going to get that person to the clinic? But we don't think about how are we structuring, what are the conditions of people's lives. And in that quote with Paula Braveman, it requires us to disrupt poverty. What are tax laws? What are living wages? Those types of things where we may think, well, that's not our lane. We're healthcare people and we're public health. No, that is our lane. The childhood labor laws back in the day, that was public health at the table saying this is damaging the health of children. And so realizing that we do have power, we have influence, and simply getting out of our own silos to think about what are those conditions that we're also responsible for.
This next question is for Vernice, and I know we're having just a little bit of technical difficulty, so I'm hoping you can hear this, Vernice, but Black infant deaths are more than twice the amount higher than white infant deaths. I remember hearing this statistic actually when I first started at Michigan Radio now 17 years ago. And these statistics continue. I just need to put that out there that these conversations are continuing. But can you, Vernice, share what you believe have been the main contributing factors leading to this disparity and how we can help address them? Oh, now we can't. Oh, no. Well, I know earlier you had jumped off and came back on, so maybe you want to try that again. We'll go to the next question, but I really want to hear from you on this because, again, we just keep talking. We know the solutions, but they need to actually happen. Or
Can
Dr.
I elevate a couple of remarks that Vern made earlier about listening to moms? I
Yes.
mean, when you look at if you go back and look at those 3 videos, those movies that I happen to list, the consistent theme is, I went to my doctor. I told them something is not right. And they said, oh, you're just postpartum, or, oh, pregnant moms feel this way. That's okay, just go. I did in my own research when I was at Michigan State as a full-time researcher, doing qualitative studies with having a mom say, my doctor told me, just go home and put your butt up, put your feet up or something. And she's like, is he allowed to say that to us? But just completely discounting until it's absolutely physiologically unarguable. Oh, this mom is crashing. Oh, this baby's doing terrible. When for months, mothers and their families, even their mothers, have been saying something's not right. So why is it that we don't honor the voice of women? It speaks to how much we value women and that power imbalance when you get into the healthcare system. That is often a racialized experience. It happens for all moms. Let me tell you that our white maternal and infant outcomes, if white women were their own country, I saw this statistic said, they would still rank in the bottom third of an international comparison. So white women are not doing well, and Black and Indigenous women are doing even worse. So how do we honor voice? How do we get solutions that come from the lived experiences of these moms?
Amy, what are some policy strategies that can be put into place to address the health inequalities that pregnant women and infants are facing?
Yeah, thanks for the question, Zoe. We've been sort of intently studying sort of what works in this space. I think Renee says we know we have a lot of services and programs and things that we've created that we know can help. But how do we intentionally focus those really on decreasing the rates specifically for Black and Indigenous families? And so how do we look at the policies that we already have and how do we target them? And so, we definitely need to do lots of the things that we've already talked about today around implicit bias training, requiring those things. Policy so often, and Megan might be able to elaborate on this, is an imperfect tool, right? Because it's built to sort of universally apply something, and yet we're trying to very much focus ourselves. And so we need to think about how do we address, build policies like the postpartum extension, but at the same time also target resources. And so we need to prioritize funding to areas where we know that the infant maternal mortality rates are higher. We need to, empower community-based organizations that are led, by Black individuals. We need to listen and really find out what those barriers are and then target the policies and the appropriations and the incentives towards those things. I think we probably have, a fair number of health plan folks on today. And there's so much that health plans can do through incentivizing their networks, working with specific populations who are enrolled, and really in that way, go beyond just the contract that the state might have with them or an employer might have with them, and really say, how do we, in our unique space, try to really target some of the things that we're doing. We talked, I think it was mentioned earlier, about workforce supports, trying to make sure that the workforce is concordant with the population. We've got to do more. We've got to really find out, how we can take things like, loan repayment, and how do we really make that actually useful to the individuals that we want to see enter the field. And so we got to dig deeper. I think policy is one thing, putting great policies in place, having a supportive governor and a supportive legislature has been amazing. Renee talked earlier about, we really need to have these things in place and really be thoughtful about them. We also have to sustain them. And that has been a huge, huge problem. We come in with policies and we come in with appropriations in the maternal and infant space, and we are not going to move a ship that is, has been so hard to turn. We're not moving it overnight. We need to sustain so many of the good things that we're doing, and then we need to keep doing more. And then we need everyone to be part of getting engaged, no matter what their position is, because Renee already said this is a societal issue, and we must really dig deep and all work together. So I'd love to tell you there's one or two policy things. Legislators always ask me, what's the one thing I can do? This is not a one thing. This is a multiple hands thing, as I would have told my kids. Like you got to do all the things, and then we need to keep thinking about more things we can do.
And continue to do it. Bernice, you were going to jump in, I think.
All right, I'm glad to be back. I keep getting, kicked out.
We're so glad you're back.
I know you're wrapping up, so I just wanted to add that this problem can seem so complex, and it's just fraught with emotion, so sometimes people get overwhelmed, i.e. immobilized, and that's what we don't want people to do. This is a huge elephant. There is a place for you. Wherever you sit, there's something you can do to begin to make a difference. But you do have to learn the history, a little bit of introspection, and conferences like this, discussions like this, that provide resources is really the first step in the right direction. So just the fact that so many people are here, you are here to learn and you are here to do. And I think that's been laid out from Megan, Renee, certainly Amy and myself, a lot of options, but don't get overwhelmed. Just take that first bite and you'll see how easy it is. Take that first bite, collaborate, pay attention to the data, find out where you fit, because you do fit somewhere in making this change. So I just wanted to add that as kind of sort of a closing remark, even though I missed a lot of what you guys were saying because I was out.
No, I think it's a powerful closing remark, because I think you can sit through this, you can hear the statistics, you can hear the data. To Dr. Kennedy's point, we're hearing that this has been a decades-long situation, and it can be really easy to just go, well, but I think, again, you women who are doing the work, who know the answers, and then the folks who are watching this again as stakeholders can be really, really instrumental in making change and creating some productive outrage. Dr. Kennedy, I'm just very curious, and maybe only, oh yeah.
One more thing.
Sure.
I mentioned that SimQuick is offering viewings and discussions around the video toxic, and you also have that, in the chat. And it is a day in the life of a Black woman that really focus on issues around, microaggressions and its impact on both maternal and child health. So, all of our links are right there in the chat. So, sorry.
No, there are no apologies necessary when we're sharing vital information. As a journalist, I cannot endorse that anymore. I do want to just deeply thank you all for your work, for your brain space, for your knowledge, and for continuing to do one bite at a time and living in this space. We're again, hopefully maybe going to have time for a quick question or answer, but I'd love to bring Tereska back in to the discussion here. Tereska, can you talk a little bit about Molina Healthcare of Michigan's role in moving forward as a partner and just tackling these really big issues that we're talking about?
I'd be happy to. Thank you, Zoe. And thanks again to Renee, Amy, Megan, and Vern for joining us today for this discussion and how we can use productive outrage to disrupt driving action and sustain change. On behalf of Molina Healthcare of Michigan and the Molina Cares Accord, we really appreciate everybody taking time to be here today with us. And I'm pleased to share that Molina Healthcare of Michigan, with support from the Molina Cares Accord, is making an over $3.5 million multi-pronged commitment to meaningfully address inequities in maternal, infant, and children's health and healthcare in Michigan, including new food, environmental health, and housing programs that include, among others, a comprehensive Healthy Beginnings program to wrap additional prenatal services and supports, including expanded access to doulas as supportive partners within the care team, food delivery services, focused efforts on existing inequities within our healthcare ecosystem that lead to poor health outcomes, and other strategic and tactical approaches. As part of this program, we are introducing new provider incentives, to the point made earlier, to reward quality, positive health outcomes and meaningful reductions in existing disparities, and for providers implementing the policies that Vern mentioned earlier, and also elevating awareness of the short movies referenced earlier so that a larger provider community can see them. And we have trained all of our healthcare services member-facing team members on trauma-informed care and are introducing additional all-team trainings. Combating institutional and structural racism and implicit bias is a focus and a theme throughout our entire Healthy Beginnings program. We're also launching new programs and grant investments to reinvigorate our services provided to children in foster care. We have stood up new programming with more to come to address housing insecurity in more meaningful ways for those with emergency housing needs to those experiencing persistent homelessness. And early this fall, we are launching a new environmental health initiative for lead and asthma affected families to help address the physical environment in which people live. We are ensuring the people we serve have a voice at the table, to the point made earlier, with their own lived experiences, and we are actively listening to our members to inform our work and make it more responsive to their needs and experiences. And we thank all of our community partners and stakeholders engaged in the ideation and launch of these exciting new opportunities for meaningful and accelerated impact. And again, just thank you to our keynote speakers, panelists, and to you, Zoe, for being part of the solution and sharing your perspectives and important work with us today. These type of conversations that generate collaborative ideas and actions between organizations across the healthcare ecosystem are a must. And Molina is really proud to convene thought leaders like yourselves as a call to action for our collective moral imperative in Michigan to make a meaningful difference for women, infants, and children.
Tereska, thank you so much for that. I know we only have a minute or so left, probably not enough to get into deep Q&As here, but so I think I want to look to Dr. Kennedy and take a moment back to your opening remarks. And again, thank you for sharing your personal story. And it's just really resonated with me over the past hour. And so I think I want to build on it and say, this experience that you had changed you. This was decades ago. And I'm just curious, as you look around our state, as you look around our community, I mean, have we made real progress? Can we? Give us some hope here as we end.
No, we have accomplished a lot in Michigan. You hear the things that Bernice listed, the legislative things, the policy things, the community things. But I would offer that we've accomplished a lot in Michigan because we're in relationship. I call Amy, I call Bernice after hours, I reach out to Megan. We know each other personally, professionally, and we're in partnership. My favorite relationship quote says, relationships are primary. All else is derivative. And so if you're not in in a deep and trusting relationship with someone with whom you can lock arms and advance change, go make a new friend. Find someone you can play patty cake with on the good days and the bad days, because that is from which change comes. So thank you, Zoe, so much.
Building that table with more and more chairs. Teresa, I'll throw
Absolutely.
it back to you just for these final, and thank you again so much, everyone, for your time.
Well, thanks again, everybody. Just today's conversation has been incredibly important, and really appreciate and like to express my gratitude for all of our panelists for being part of today's conversation, and thanking our attendees for joining to hear more about these issues and how we can all play a part in strengthening Michigan for the future. To learn more about Molina's work in the state or to view today's panel discussion, please visit molinacares.com, and have a great rest of your afternoon, everybody.